Welcome everyone to the 2023 Post-American Society of Hematology Annual Meeting CME series. We are starting off the series today with multiple myeloma. Our first two presenters are Dr. Noffar and Dr. Sabrina Browning, who will be reviewing abstracts. We will then have a question and answer period at the end of the presentation, where we will be joined by two other panelists, Dr. Elan Gorshein and Dr. Natalia Neparidze. If you could please put your questions in the Q&A and save them to the end, that would be greatly appreciated. I will now turn it over to Dr. Barr.
Hi, everyone. I'm just going to start sharing my screen here. All right. It's good to be here. Good afternoon. Today, I'm going to be looking at the newly diagnosed myeloma abstracts in ASH of 2022, this past December, with a particular focus on subgroups. So I have no disclosures. The first subgroup I'm going to be speaking about are the frail patients. And why is it important to have dedicated studies for these folks? Is that they have different outcomes. They have shorter survival, they have higher rates of toxicity, and therefore higher rates of discontinuation of therapy. Traditionally, studies have categorized myeloma patients as either transplant or transplant ineligible patients. But this category really does not capture frail patients because frail scores are not routinely checked in those non-transplant eligible patients. For a long time, the standard of care for non-transplant eligible patients was with Revlimid and dexamethasone, RD. But since the MAIA study, we now have a new standard of care for patients, which is daratumumab, Revlimid, and dexamethasone, DARA-RD. So what the IFM 2017-03 study analyzed is removal of dexamethasone early. So they hypothesized that if you take away dexamethasone from DARA-RD, this will still be effective and it will reduce toxicities. Before we get into the study design, I want to talk about what is a frailty score. Some of you might not have had a chance to take a look at this in your clinic. So IMWG frailty score involves a few things: age, activity of daily living, which involves feeding oneself, bathing oneself, instrumental activities of daily living, which involve food shopping, cleaning the house, doing your finances, and the comorbidity index, which is what it means. Comorbidities like lung disease, diabetes, liver disease, and so forth. Now, as you can imagine, this takes time to do this frailty score. There was a lot of questions involved. So the IFM group devised a simplified score, which involves age, which is fairly easy, ECOG performance status, which we do routinely, and then the comorbidity index, which is easily accessible from chart review. And if you had a score of 2 or more, you're classified as frail, and otherwise you're fit. So this is the study design. They included newly diagnosed patients over 65 years of age and an IFM frailty score of 2 or above. It was a 2-to-1 randomization with Revlimid Dex or DARA Revlimid. I do want to note that with the DARA Revlimid group, which arm B right here, they did receive steroids for the first 2 cycles along with dexamethasone, primarily to avoid infusion reactions. So their primary endpoint was PFS, but this is immature at the moment. So they did an interim analysis and they looked at response rate, including MRD negative rate and occurrence of grade 3 or more toxicities. I want to highlight here some of the patient characteristics. So if you look at the median age, they were significantly older, median age of 81, compared to the MAIA study, which was 73. While the inclusion criteria in the study included 2 or, for the frailty score was 2 or higher, actually the majority of the patients were 3 and higher. If you look at the risk categories, they were fairly similar in the 2 groups. So DARA Revlimid clearly led to deeper response rates than Revlimid dexamethasone. You can see here first, based on just the response rates, you had higher CR and very good partial response rates in the DARA Rev group. And you also had higher MRD negative rates, a 10 to the negative 5th, using next generation sequencing, 10 compared to 3. MRD was assessed at 1 year in patients who had a very good partial response or higher. It is important to note that any missing data was considered MRD positive. So it's important because there is a significant group of patients that have missing data. For example, the DR group had 20% missing data, and the RD had 14% missing data. And I'm not about to compare different studies to one another, but I want to give us a framework of what the Maya study showed. So in the Maya study, they assessed MRD negativity at 10 to the -5th, but they used a different assay. So they used flow. So flow tends to have a higher MRD negative rate just by the nature of its assay. So just something to note. But they had in the DRD group 24% MRD negativity versus 7% in the RD group. In terms of toxicity, which is very important, you can see that grade 3 or above toxicity was higher in the DR group, particularly with hematologic toxicities like anemia or neutropenia. And in this group, of course, you worry about infections with this neutropenia, but they did not see an increase in grade 3 and above infections in the DR group compared to the R group. And even when looking at patients who are very frail with scores of 4 and 5, there was no difference in grade 3 infections. So this is reassuring. So in conclusion, I think it is time to rethink duration of dexamethasone, especially in frail patients. Longer follow-up of PFS is needed, but higher MRD rates in the DR group is very promising. I think a better comparator to DR, like DRD in Maya, would have been a better design. However, this was not the standard of care when this was designed. They are going to have a retrospective comparison to the Maya study in the frail population. I think, right now when you see patients in clinic, when you have that very frail over 80-year-old patient where you're really not sure about triple drug induction and you're thinking about the doublets, I would choose Dara-Rev with a short duration of steroids as opposed to Rev-Dex. So I do think it's meaningful for our practice today. The next set of subgroups I want to talk about, another area of very high unmet need is the high-risk population, where we really have limited randomized studies guiding our treatment. The only randomized study was a negative one, and this was evaluated the addition of elotuzumab to Velcade, Revlimid, and dexamethasone, VRD. Now, we know we need to do better than VRD, but how do we do it? So one appealing option was switching out the Velcade with carfilzomib, which is a more potent proteasome inhibitor, and outperform Velcade in the relapse refractory setting. Additionally, there was phase 2 studies showing high MRD negative rates in KRD. So it made sense to compare VRD to KRD, and they did this in an endurance study, the endurance study. And they actually did not find superiority of KRD to VRD, but they excluded high-risk patients. So that question about how do we better improve our induction in the high-risk patients was not really answered by this study. But people have not abandoned KRD in high-risk patients for a variety of reasons. But in the Memorial Sloan Kettering group, where they were early adapters of KRD in induction, they were able to do a retrospective analysis, and this was presented by Dr. Tan in this year's ASH, of KRD versus VRD in high-risk myeloma. Their inclusion criteria for high-risk included having gain of 1Q, translocations 414, 1416, 1420, and deletion 17p. They identified 154 patients in this category. 67 had VRD and 87 had KRD. About 50% of each of these groups underwent early stem cell transplant. Their primary endpoint was progression-free survival, and they also looked at response rate, including MRD negative rate and overall survival. So this is the patient characteristics. A few things to highlight. The KRD group were younger. And then I want to look at the cytogenetic characteristics here just to see who are dealing with. Majority of the patients who are high risk were high risk by definition of chromosome 1q gain or amplification, which is not unusual because this is one of the more common findings we see. The second most common was deletion 17p. And importantly, about a quarter of the patients in each group had 2 or more high-risk cytogenetic abnormalities, and this is now called the double hit or the ultra-high-risk patients, which really have poor outcomes. So this is the response rates and the median PFS results. You see higher CR rates with KRD compared to VRD, higher MRD negative rates by flow, but it was not statistically significant. I think the most impressive results is the PFS, with KRD having a median of 71 months compared to 41 months. And this was, highly statistically significant. And they also saw an overall survival benefit with a 5-year estimate of 85% compared to 63%. I want to just point out here in the endurance study, remember, so these non-high-risk patients, the PFS of both arms was 34 months. And it's not quite clear why in this high-risk populations the PFS is actually higher. So this was kind of brought up to the presenter, and there wasn't a great explanation, but something to think about. Endurance was done in a lot of community setting, and this study is in a single institution tertiary center. So next, they did a multivariate analysis looking at different factors that are associated with better PFS and OS. So first, type of induction, so KRD was better, early transplant was better, having revised ISIS 1 compared to 2 or 3 was better. And that, who are these revised ISIS 1 in this high-risk patient population? It's really those patients that have gain of 1Q, because they were not included, it's not part of the revised ISS criteria. So you know who these patients are. And then the number of cycles, having 6 or more induction cycles, had better PFS and OS. So to summarize, I think this study is interesting. It does suggest that maybe KRD could be better than VRD in high-risk patients, but it is very limited by the retrospective nature of this design. I also think that they don't talk about which maintenance strategies they used, and that will definitely impact PFS and OS. I think this study continues to support the notion that early transplant in high-risk patients is beneficial, and it does bring into question what is the optimal number of induction treatments in high-risk patients? Next, I want to move to a more modern question is, now that we're using quadruplets, how do high-risk patients fare with the most commonly used quadruplets, the DARA-VRD? So DARA-VRD was studied in the Griffin study, which compared the addition of DARA to VRD in transplant-eligible patients. In all patients, they saw that there were higher MRD rates and also progression-free survival benefit. But again, this is in all patients. There were only 15% of those patients in the study that were high-risk cytogenetics by the traditional high-risk features like deletion 17, translocation 414, and 416. So Dr. Chari wanted to evaluate. He evaluated this subset group in the Griffin to really hone in on different high-risk categories in the Griffin study. And I want to really, it's a little bit busy slide, but let's just focus in on the cytogenetic risk categories here as I highlighted. As I mentioned, the initial high-risk category were very few in both arms, but then they revised their high-risk category to include chromosome 1 abnormality, and that really increased their patient population from 16 to 42 patients in the DARA-VRD and 14 to 37 patients. And then they categorized patients having 0, so no high-risk features, HRCA, 1 high-risk cytogenetic abnormality, or 2 or more, as we call the ultra-high-risk patients. Clearly, you can see the PFS in patients who are standard risk didn't seem to differ much between the two groups. Both of them were not reached in a median of 50 months. Clearly, the ultra-high-risk patients are too small to really make any conclusions about, only 10 patients and 8 patients. But in the high-risk, in the 1 high-risk cytogenetic abnormality group, there was an improvement in PFS not reached compared to 48 months. And this is the only subgroup here that actually does not cross, the hazard ratio does not cross 1. So a different way of looking at the same data, if you're a more visual person, is looking at the PFS curves. And what I want to show here in the kind of medium purple line, the DARE-RVD with one high-risk cytogenetic feature, compare that to this green dotted line here, the DARE-RVD with, with a VRD with one high-risk feature. There's a clear separation of the PFS curves. While there is really not a big difference with those patients who are standard risk, and clearly the ultra-high risk do poorly. Now look at the graph on the right. These are the amplification or gain of 1Q, and the graph is actually pretty identical to the ones with the one high-risk cytogenetic abnormality, which really shows you who those patients are. So in conclusion, I think this analysis shows that DARE-VRD seemed to outperform VRD in high-risk patients harboring gain of 1Q. High-risk patients with more than two cytogenetic abnormalities do poorly, and we can't make any conclusions with this analysis because the numbers were too small. So this brings me to this category of ultra-high-risk myeloma. And the Optimum study was a very clever study in the UK. It was a screening study. So anyone in multiple UK centers who was being worked up for myeloma was offered participation in the study, and they screened patients for high-risk features. Their inclusion was to be double hit. So you have to have two of the following: translocation 414, 1416, deletion 1, gain of 1, so deletion 1p, gain of 1q, and deletion 17p, or high-risk gene profile, or if you had plasma cell leukemia, which really is, these patients are excluded from every study. They identified 107 patients, 10 of which had plasma cell leukemia. So there's a few things going on in this study. I want to focus first on the study design of the Optimum study, which we talked about up here on top. They used 5 drugs in induction. So they added Cytoxan to DARE-VRD. They added Velcade in the peri-transplant period. They used 6 cycles of DARE-VRD induction and then 12 more cycles of DARE-RD in extended consolidation, so basically excluding steroids, in another year of consolidation too. And then DARE-R in until progression. And notably, they're not using proteasome inhibitor long-term. So ideally, the authors love to have done a randomized study, but there was no standard of care for these ultra high-risk patients. They thought it was unethical, so they did not do so. So it's a single-arm study. But they were very much interested in understanding how this would compare to a genetically similar group of patients with myeloma. So they looked at their Myeloma X study, and they had genetic testing for all these patients. They identified an identical population with this ultra high risk phenotype. I'm not going to go into the details of that study because I do think it's an overall subpar comparator, but it's just for numerical purposes here. They used Cytoxan, Revlimid Dex, or Carfilzomib, Cytoxan, Revlimid Dex in induction, transplant, and then either they got no maintenance, which is really not what we do, or Revlimid maintenance. So their objectives of the study is to look at MRD, to look at PFS and toxicity. I do want to note this is quite an intensive treatment, and they did have several dropouts. So out of 107 patients, only 74 patients completed consolidation too. The dropouts in the induction transplant section was due to intolerance, and the dropout in consolidation was due to progression of disease. So this is MRD at different time points. You can see that the MRD deepened as you move from end of induction to end of transplant at 63%. I don't want you to be discouraged by the lower percentage after end of consolidation because, as I mentioned, there are dropouts. So you can see here 30% of the patients didn't reach that endpoint. So that's why you see a numerically lower rate of MRD there. What is important, we know sustained MRD is actually more relevant than just one time point of MRD negativity, is that 84% had sustained MRD negativity at the end of consolidation. So that is very impressive. Now, this is the PFS curves. Again, I'm not surprised that the PFS is better with this Optimum regimen than the comparator. They did spread out in the myeloma X, the ones that got carfilzomib or not. You see carfilzomib seemed to be a little bit better than not. Again, not very surprising with proteasome inhibitor. But regardless, I think it's very impressive, the 30-month PFS estimate of 77%. This does fare favorably to other data out there for this really high-risk patient population. In terms of toxicity, which is very relevant when people are getting this intense, prolonged treatment, they showed you here the consolidation to adverse events. So there are some grade 3 side effects. There are not that many. Most of them are hematological, like neutropenia. There were some grade 3 infections, about 12%, most of them being respiratory tract infections. And they don't separate out, the viruses from the bacteria, but I think that would be relevant, especially in the era of pandemic. So it seems to be fairly tolerable. They did, one thing to note, they did allow for very flexible dose reductions, even for grade 1 toxicity, to allow patients to continue on treatment for longer. So in conclusion, I think these type of single-arm studies can serve as comparators for future randomized studies, and of course, balancing the efficacy and toxicity in this patient population. Now, the last study I'm going to go into, I'm going to shift gears to a different subtype of high-risk patients, and these are the functional high-risk myeloma. And these are not the patients you know that they're high-risk when you first see them. They demonstrate themselves because they relapse early. So patients who have early relapse after transplant within 1 year have horrible prognosis. You see here 26 months overall survival compared to 91 months if you didn't have this early relapse. So what this KarMMa-2A study analyzed is the use of ide-cel or Abecma, which is the first BCMA-directed CAR T-cell product for myeloma. They used it in this patient population. The inclusion criteria include relapse 18 months after initiation of frontline therapy, and you had to have Revlimid-based maintenance. The primary endpoint was a CR, and secondary endpoints include duration of response, progression-free survival, and toxicity. So patient characteristics are presented here. A few things to highlight in terms of high-risk features. There were 32% high-risk disease in this functionally high-risk patients. There were 40% with missing data. They did have information about their response to upfront therapy, and 24% of the patients had a CR to their first line of therapy. Most patients had progression of disease within 12 months of transplant, and no patients were refractory to an anti-CD38 like daratumumab. This is the efficacy data. The CR rate, which I think is the most relevant in terms of the response rate, is 45%. I just put here in gray what is the CR rate that was seen in this agent in the relapse, the heavily pretreated population, which is 33%. Just like the other CAR T products, we see the deeper response, the longer duration of response. Overall, the median duration of the responding patients was 15 months, but if you had a CR, then it goes to 23 months. And if you had a PR, for example, it's as short as 3 months. So really, depth of response is extremely important. PFS is roughly a year, so 11 months here, which is quite similar to what was seen in the relapse refractory patient population. And, I think, again, this includes all those non-responders as well. I think it would be interesting to see the PFS for those who are responding. In terms of toxicity, there was initial concern that when you're using these CAR T products earlier in the line of treatment, that the T cells might be fitter, they might be healthier and actually have higher toxicities like CRS and the neurotoxicity ICANS. But they didn't see that in this study. So there were roughly the same amount, percentage of events in the CRS and the neurotoxicity group as was seen in the prior study. And actually there were lower, or at least numerically lower number of high-grade events like grade 3, 4 in both groups compared to the prior study. I do want to mention infections is still an issue post-CAR T. There was grade 3, 4 infections at 22%, and in fact 2 deaths from this with a pneumonia and another from pseudomonal sepsis. So in conclusion, in this functionally high-risk patient population, ide-cel achieved 45% CR rates, and this was higher than what was seen in the first line of therapy for those patients. It seems that there are less grade 3-4 toxicities compared to the relapse refractory population. The PFS seems similar to what was seen in the heavily pretreated population, but these patients are very high risk. They're very difficult to treat and salvage. So I think we really need randomized study to see what is the best treatment for these patients, and ideally identify those that will have a CR rate. So I want to close with this one last slide. This is what I think is the future. It's this risk-adaptive therapy directed according to response type of study. This is the RADAR study that was presented by Dr. Wong from the UK. Don't want to go into the details of all this. It's a busy slide, but the concept here is extremely important, that you separate out the standard risk from the high risk. High risk patients, we don't want to stop treatment on. We need better treatments. Standard risk that have MRD negative disease can maybe even stop treatment. And standard risk patients who don't achieve MRD negativity, how are we going to deepen the response? How are we going to get them into better MRD negative states? So, and randomizing, doing it in a randomized fashion. So this and other type studies like this are ongoing. And I think the next decade, hopefully we'll have an answer to how to personalize treatments for myeloma. And with that, I will close my section of the talk and we'll move on to Dr. Browning's.
Okay, great. Well, thank you, Dr. Barr, and welcome again, everyone. My name is Sabrina Browning, and with the remainder of our time that we have left, I'm going to review with you data on relapse refractory myeloma, and we'll also briefly touch upon a new therapeutic in light chain or AL amyloidosis. And I have no disclosures to report. So a major focus in myeloma at ASH this year was the diverse and advancing immunotherapeutic landscape for relapse and refractory disease. And as you all are familiar, B-cell maturation antigen, or BCMA, has been a critical target on myeloma cells. And as Dr. Barr mentioned, we now have 2 approved anti-BCMA CAR T-cell products, ide-cel and cilta-cel, as well as an anti-BCMA bispecific antibody, or teclistamab. And while I won't cover this today, there was promising early phase data presented on the combination of teclistamab with daratumumab and lenalidomide. And there are other combinations with this bispecific antibody that are also actively being studied, as well as a number of new BCMA CAR T invites. But importantly, the abstracts that I will focus on today with you all highlight some T-cell redirection therapies that harness new myeloma cell antigen targets. And these include G protein coupled receptor, family C group 5 member D, or what's referred to as GPRC5D, and SC receptor homolog 5, or FCRH5, as well as some non-cellular therapies that help reverse tumor-mediated immune paralysis that occurs in myeloma. And these include the novel cereblon E ligase modulators, or what is referred to as CELMods. So to start, we will discuss the phase 2 results from the Monumental 1 study, which were presented by Dr. Ajay Chari. And this evaluates talquetamab. Talquetamab is a first-in-class T-cell bispecific antibody that targets GPRC5D. And as previously discussed, this is highly expressed on myeloma cells and thought to have limited expression on normal cells, and that includes hematopoietic stem cells. And in December of this past year, the phase 1 data from the Monumental study were published in the New England Journal and demonstrated an impressive overall response rate of 64 to 70% with both weekly and every other weekly dosing. And so for the phase 2 portion of the study, patients had to have an ECOG of 0 to 2 with measurable disease and 3 or more lines of prior therapy. And this included a proteasome inhibitor, an IMiD, and an anti-CD38 antibody. And the 3 cohorts in this portion of the study that you see outlined here included a 0.4 milligram per kilogram weekly subcutaneous dosing, and 122 patients enrolled in this group. 0.8 milligrams per kilogram every other week subcutaneous dosing, where 109 patients were enrolled. And then a third group of patients who had received prior T-cell redirection therapy and were administered either of the 2 mentioned dosing schedules. And the aim of this study was to assess efficacy and safety of this novel agent. And so the table on the left here on the slide outlines some of the key patient and disease characteristics from the phase 2 cohorts of this study. Median age was 67, and 8.4% of the 0.4 milligram per kilogram group and 6.2% of the 0.8 milligram per kilogram group were Black or African American. And as one would expect in a heavily pretreated population with an average of 5 prior lines of therapy, high-risk features including extramedullary disease, high-risk cytogenetics, and ISS stage 3 disease were observed in about a quarter to a third of patients, as documented here in the table. And approximately 3/4 of the patients had triple class refractory disease. However, despite this population, again, with high-risk disease, there wasn't an impressive overall response rate as seen in the figure here on the right at 74.1% and 73.1% in the 2 dosing groups. And VGPR or better was achieved in approximately 60% of patients, which also indicates a high depth of response with this agent. These responses were maintained across subgroups, except for those with extramedullary disease, where the overall response rate was reduced some at 50%. And responses were rapid, with a median time to response of a little over a month and a median time to best response of approximately 2.5 months. And thus far, responses have also been durable. So the median progression-free survival at the time of presentation was 7.5 months and 11.9 months in the two cohorts, with a median duration of response that was not reached in patients who had achieved a complete response or better. And median overall survival was not reached for the study cohort to date. Importantly, for the patients who had received prior T-cell redirection therapy, which included 70.6% of patients who had received prior CAR-T and 35.3% who had received prior bispecific, the overall response rate was still high at 62.7%. Responses were higher in those that received prior CAR-T compared to bispecifics, although the number of patients in the study that received prior bispecifics was small, with an N of 18. It's important to consider safety for this agent, given its novel target, as we discussed. And fortunately, as you can see outlined here, high-grade adverse events were uncommon, but when they were present, they were mostly hematologic in nature. And with that being said, still there was less than a third of patients that had high-grade heme toxicities, and most of the toxicity was limited to the first few cycles of treatment. High-grade infections were also uncommon in this study, and as you can see, that included a low number of opportunistic infections. COVID infections occurred in approximately 10% of patients, with only 2 deaths from COVID, and actually 0 deaths reported in the phase 1 portion that was published in the New England Journal back in December, as mentioned. Rates of IVIG use were also relatively low, with less severe, and this less severe infection signal that we're seeing with this agent is somewhat distinct from our anti-BCMA targeted bispecific antibodies that are now in utilization. The most common adverse events were cytokine release syndrome, or CRS, as well as altered taste or dysgeusia, skin and nail related events as well. And the CRS events appear to be restricted largely to step-up dosing and first full dose, with a median time to onset of 2 days. Immune effector cell-associated neurotoxicity, or what we refer to as ICANS, occurred in about 10 to 11% of patients, but again, were mostly low-grade. So in conclusion, talquetamab, which is a first-in-class bispecific antibody, again targeting novel GPRC5D on myeloma cells, demonstrated an impressive overall response rate of more than 70% in patients with heavily pretreated relapsed and refractory myeloma, and high overall response rates were also seen in those who had received prior T-cell redirection therapy, which is an important cohort to learn more about. Responses have been durable, and the agent has generally been overall well tolerated, with CRS that seems to be manageable and fewer infections, although it does have unique safety profile, and those include things like skin and nail related events, as well as taste alteration or dysgeusia, as previously mentioned, although these were generally managed with supportive care, and there was a low overall rate of discontinuation due to the adverse events. And therefore, there are additional studies that are now ongoing to look at talquetamab both in combination with a variety of different anti-myeloma agents. And so next I want to briefly share with you the following abstract. This was presented by Dr. Jesus Bordeja, and this is now a novel CAR T cell therapy that's targeting GPRC5D. And this CAR T construct is seen in the figure here on the right. And this data came from a phase 1 multi-center open label study. And the data was presented on 33 patients enrolled in the Part A dose escalation cohort. Eligible patients had relapsed refractory myeloma with 3 or more prior lines of therapy, and prior BCMA therapy was allowed. There were 5 dose levels that were tested, ranging from 25 to 450 million CAR T cells. And thus far, the overall safety and efficacy profiles have been favorable. Treatment emergent adverse events were seen in close to 88% of patients, and 73% of patients had grade 3 or 4 adverse events. And in comparison to talquetamab, hematologic adverse events, and particularly neutropenia and thrombocytopenia, seem to be more common, with a dose-limiting toxicity of prolonged grade 4 neutropenia and thrombocytopenia in 2 patients. Again, CRS was the most common non-hematologic adverse event at 63.6%, and the median time to onset with this CAR T was 3 days, although grade 3 and 4 CRS events were only observed in 6% of patients. ICANS was infrequent, with only two patients, and was reversible in both instances with steroid treatment. Again, because of the GPR, the unique target that this CAR T targets, there were skin and nail related adverse events, as well as taste alterations, but these seem to be less common than talquetamab, and all were low grade, and the majority did not require any sort of treatment. The maximum tolerated dose has not yet been exceeded in this study, and there have been no deaths thought to be related to study treatment. Importantly, the overall response rate of the total cohort was high at 89.5%, with a CR rate, a complete response rate of 47.4%. And there were 4 patients that were evaluated for minimal residual disease, or MRD, and all 4 of those were MRD negative. So in conclusion, responses with this novel CAR T seem durable and seem to also deepen over time, making this a promising treatment moving forward, including in those patients that are already exposed to BCMA treatment. The next abstract that I will present was discussed by Dr. Susan Trudell, and it looked at one cohort in a safety and efficacy trial of cevostamab. And cevostamab is a bispecific antibody, seen here on the right, that targets yet another new myeloma antigen known as FcRH5, which again is exclusively expressed in B-cell lineage and is thought to be near ubiquitous on myeloma cells. And at ASH in 2021, there was initial data presented from the phase 1 dose-finding study of cevostamab, and revealed a favorable efficacy and safety profile in those patients with heavily pretreated relapse and refractory myeloma. This year's abstract reviewed a cohort in this study who received a single dose of the IL-6 receptor blocker tocilizumab at 8 milligrams per kilogram, and this was given 2 hours prior to the first cevostamab step-up dose, which is 3.6 milligram. And these patients were then compared retrospectively to a previously enrolled group who did not receive tocilizumab. And the objective, which was based on preclinical data, was to determine whether this would reduce the frequency of cytokine release syndrome, or CRS, which, as we've discussed now in several abstracts, is one of the most common adverse events with bispecific antibody treatment, and is thought to be mediated by IL-6 and other cytokines. And as you can see here on the bottom, cevostamab is administered with a single step-up dose, initially at 3.6 milligrams, and then to a target dose of 90 milligrams. And it's given intravenously every 3 weeks. So 31 patients were enrolled in the tocilizumab pretreatment arm, with 44 patients in the comparator arm. And both groups, as you can see in the table here on the left, included heavily pretreated patients, with a median median line of therapies being 4 and 6 respectively, with fairly similar patient and disease characteristics, except for those that I've highlighted for you here in the table on the left. And as you can see, the tocilizumab pretreatment group did have somewhat less extramedullary disease, as well as less pentadrug refractory disease. And fewer patients in the tocilizumab arm had received prior anti-BCMA cell therapy. The most commonly observed adverse events in both groups were neutropenia, anemia, thrombocytopenia, and CRS. And of note, neutropenia, which is a known side effect of tocilizumab, was significantly higher in the toci pretreatment group, but was said by the authors to be reversible and manageable with growth factor when appropriate. And this did not lead to cevostamab discontinuation. The infection rate was also reportedly higher than the comparator arm, although compared to other cohorts in the study, there was a similar infection rate, and grade 3 infections also occurred at a similar rate between these two study groups. And as you can see in the figure here on the right, the overall rate of CRS was significantly lower in the toci pretreatment group at 38.7%, compared to the non-toci group at 90.9%. CRS was limited to grade 1 and grade 2 events in both cohorts, in both groups, with a median time to onset of 1 day, and the beneficial effects of toci on CRS were continued with subsequent doses in cycle 1 in the tocilizumab pretreatment arm. ICANS was seen infrequently in both groups, occurred in only 2 patients in the toci arm and 6 patients in the non-toci arm. And interestingly, the authors demonstrated in the toci pretreatment arm that after the first 3.6 milligrams cevostamab dose, there were higher peak levels of IL-6, which were hypothesized to be due to inhibition of IL-6 clearance by the tocilizumab. However, there was also near complete suppression of CRP, which is produced by IL-6 receptor binding, and thereby suggesting that there was effective blockade or blockage of the IL-6 inflammatory signaling pathway. Also importantly, pretreatment with tocilizumab did not appear to negatively impact clinical response rates, with an overall response rate of 54.8% and a very good partial response or a VGR or better rate of 32.3% observed in the toci group. And that was compared to an overall response rate of 37.2% and a VGPR or better of 25.5% in the non-toci arm. And median time to best response, as well as median duration of response, was similar between the two groups. So in conclusion, pretreatment with a single dose of tocilizumab prior to the initiation of cevostamab significantly reduced the rate of CRS in patients with relapsed refractory myeloma, likely thought to be through suppression of the IL-6 signaling pathway, but did not seem to negatively impact the anti-myeloma activity of this agent. And so the authors noted that tocilizumab may play an important future role in CRS mitigation as pre-dosing and may potentially help us move bispecific treatment to the outpatient setting. The next abstract was presented by Dr. Paul Richardson, and this was on mezigdomide, or what's referred to as MEZI. And MEZI is a potent novel cereblon E ligase modulator, or what we know as a CELMoD. And this was looked at in combination with dexamethasone in this abstract. MEZI is an oral agent, and as can be seen in the figure here, it binds and activates cereblon, and it leads to, what happens is it leads to maximal degradation of important transcription factors, and that includes Ikaros and Ilos, that are both really important in myeloma pathophysiology and pathobiology. And this results in enhanced myeloma cell killing and immune stimulatory activity when compared to our common immunomodulatory drugs such as lenalidomide. And in this phase 1/2 trial, MEZI was evaluated alone and in combination with dexamethasone, and the recommended phase 2 dose for MEZI was selected at 1 milligram daily for 21 days out of a 28-day cycle, with a notable overall response rate in the phase 1 portion of 54.5%. And to be eligible for the phase 2 dose expansion portion of the study that was reported in this abstract, patients had to be relapsed refractory and have had received 3 or more prior lines of treatment and be refractory to at least one immunomodulatory agent. Again, prior exposure to BCMA therapy was allowed, and dexamethasone was administered at 20 to 40 milligrams dependent on age in combination with MEZI. The main objectives of the study included efficacy and safety of this novel combination. So 101 patients were included in the MESI plus DEX cohort, and their patient and disease characteristics are outlined in the table on the left. Median age, as expected, was 67 years, and these were heavily pretreated patients with a median time since initial diagnosis of myeloma of 7.44 years, a median of 6 lines of prior treatment, and 100% of patients were triple-class refractory. There were only approximately 20% of patients with ISS stage 3 disease, although 39.6 had extramedullary disease, and this included in their study soft tissue bone-related plasmacytoma in addition to true soft tissue extramedullary disease. And 36.6% of patients had high-risk cytogenetics. 29.7% of patients had received prior anti-BCMA treatment, mostly in the form of antibody-drug conjugates. And in terms of clinical activity, as you can see on the figure here on the right, the overall response in the total population of was 40.6%, with a high quality responses that included a stringent CR, complete response, and VGPR. And in those with extramedullary disease, the overall response rate was still notable at 30%. And patients who had received anti-BCMA treatment, although small in number, with 30 patients total, had an overall response rate of 50%. And while follow-up is short to date, the median progression-free survival observed was 4.4 months, and median duration of response was 9.2 months when patients achieved a VGPR or better. And Dr. Richardson presented some correlative data from this abstract as well, showing that MESI is active in patients who are either refractory to pomalidomide or Pomalyst, and in those receiving pomalidomide as in their last regimen or as their last regimen of treatment. At a median follow-up of 7.5 months, 90.1% of patients had discontinued treatment, although the majority due to progressive myeloma. 5 patients were reported to have adverse events related 5 patients were reported to have adverse event related deaths, including 2 with PJP pneumonia, an additional with pneumonia, and 1 due to COVID-19 infection, and 1 due to septic shock. And while a majority of patients did require dose interruptions due to adverse events, dose reductions were less common. And a few patients discontinued drug due to adverse events, as is outlined here. And as you can see in the tables here on the bottom, treatment emergent adverse events were primarily hematologic in nature, with neutropenia being the most common, although this was felt to be manageable again with dose adjustments and growth factor support. Additionally, infections were the most common non-hematologic adverse event, with infections of any grade seen in about 2/3 of patients. Other observed side effects are listed here in the tables, although they were less common and less severe. So to summarize, mezigdomide or MESI is an oral potent novel cell mod, which in preclinical studies has a distinct profile from our immunomodulatory agents. And when combined with dexamethasone, overall response rate was notable at 40.6% in the total cohort and 30% in patients with extramedullary disease. The safety profile was manageable, with most higher grade adverse events being hematologic in nature and most commonly neutropenia, which did require some dose adjustments and GCF support when needed. Given these findings, MESI is now being evaluated in combination with standard myeloma therapies, including in phase 3 trials with bortezomib and carfilzomib. And this appears to be a promising agent in patients with heavily pretreated relapse refractory myeloma, including those who may be refractory to IMiDs, including Pomalyst. So I will shift gears a bit now with this last abstract and discuss light chain or AL amyloidosis, which, as you guys likely know, is a rare progressive disorder where clonal plasma cells in the bone marrow produce immunoglobulin light chains that misfold and then form amyloid fibrils that become insoluble and deposit in extracellular tissues and organs, resulting in significant dysfunction. And we have made advances in the treatment of AL amyloid with exciting data from last year's ASH on the Andromeda trial, which showed improved hematologic and organ responses with the addition of daratumumab to CyBorD. However, these available therapies target the clonal plasma cells in order to stop or halt production of light chains, new light chains, but they don't address the amyloid that's already been deposited in end organs that lead to significant morbidity, and in patients with advanced cardiac disease, high mortality, with a median overall survival in patients with Mayo stage 4 disease of only 5.8 months. And the abstract I will discuss was presented by Dr. Maury Gertz from the Mayo Clinic on bertamimab, which is a humanized monoclonal antibody administered intravenously every 28 days and binds conserved epitopes on both kappa and lambda immunoglobulin light chains. And that leads to neutralization of circulating light chain aggregates, as well as depletes the insoluble amyloid deposited in the organs thought to be through phagocytosis by macrophages. And the study schema here on the top outlines the phase 3 VITAL study, which is a multi-center, double-blind, placebo-controlled trial in patients with newly diagnosed treatment-naive AL amyloid. All patients enrolled had cardiac involvement and were stratified by Mayo stage, renal stage, and 6-minute walk test. 260 patients total were enrolled and randomized to receive bertamimab in addition to standard of care or placebo with standard of care. There was an interim futility analysis back in 2018 that actually resulted in early study termination, given concern that the primary endpoint, which was all-cause mortality or time to all-cause mortality, would not be met in a reasonable amount of time. And so afterwards, a post hoc analysis was performed on 77 patients that had Mayo stage 4 cardiac amyloid. And this has previously been reported to show, as you can see in the Kaplan-Meier curve here, a survival benefit with significant reduction in time to all-cause mortality in this cohort, with 74% of patients in the bertamimab group being alive at month 9, with only compared to only 49% in the placebo arm, with the hazard ratio that you see listed here. So in this year's abstract, Dr. Gertz and his co-authors showed, using the data from the post hoc analysis, that reduction in time to all-cause mortality at 9 months, favoring the bertamimab arm, persisted in these Mayo stage 4 patients, even after adjusting for a variety of demographic and disease characteristics, as you can see in the forest plots here, that come from small numbers, but have, again, impressive hazard ratios. There was also, in the post-hoc analysis, patients who received bertamimab had less deterioration in quality of life and improved 6-minute walk test. And so with the available data, bertamimab has been safe and well tolerated, even in these patients with advanced cardiac disease. And it has, this data has served as the foundation for the AFFIRM-AL trial. And we have this trial open here at Yale, as well as in a number of our care centers in Trumbull and St. Francis. And AFFIRM-AL is looking to enroll patients with newly diagnosed treatment-naive AL amyloid with Mayo stage 4 disease, with the criteria listed here. And looking again to see if we see this survival benefit that was demonstrated in the post hoc analysis. And patients will be randomized 2-to-1 to receive bertamimab in addition to standard care. And I do think this is an incredibly important trial for a very complex, very hard to treat population. And I would be happy to talk with anybody interested who might have eligible patients or have questions about the trial. So in summary, we saw many exciting abstracts at ASH looking at new myeloma target antigens from bispecific antibodies and CAR-T, as well as abstracts looking at improved manufacturing and management of side effects, including CRS. I will end so that we can move to the questions and answers by just saying that, although not covered today, there were up to 30 abstracts looking at health disparities in multiple myeloma, which remains really a critical unmet need, and ongoing investigation is really imperative. The QR code I've included here links to a video by Dr. Joel McHale and the International Myeloma Foundation addressing some of these really important abstracts. So thank you again all for your time, and I look forward to answering some questions.
Thank you, Sabrina and Noffar, for those excellent reviews. We do have time for questions, so I would encourage everyone to please place your questions, if you have any, in the Q&A portion that can be found below on the screen. As we wait for questions, I will start by asking a few. Maybe we'll start with Elan and Natalia. We heard a lot about side effects from the bispecific T-cell engagers, the CAR Ts, and even the cell mods in relationship to infections. So how would you propose we manage that risk to help keep our patients safe as these therapies move forward?
I mean, I guess I can start. We know that there's a risk of hypogammaglobulinemia with this patient. So I think that keeping a close eye on the IgG level, making sure that it's, consistently at least 400 or even 500, compliance with, antiviral, antimicrobial prophylaxis. And I think also just educating, the various colleagues and members of the community and the oncology team about the risk for infection complications in these novel agents.
I think, Natalia, you're on mute. Oh, you're still muted. Natalia, you were still on mute, so unfortunately, we've not been able to hear what you have said. And we can move on. We did have one question from the audience, which is asking if calcium deficiency is seen in multiple myeloma. I don't know if anyone wants to take the question regarding calcium in multiple myeloma.
I mean, I think that usually with myeloma, we see hypercalcemia. And I think if it's poorly controlled, we can see hypercalcemia. The bisphosphonates and the bone modifying agents can cause hypocalcemia, but typically we would see hypercalcemia.
Thank you, Elan. So I may ask a question that's a little bit unfair to the group, and we can have each of the panelists answer. With all of these new targets in the relapse refractory setting, how do you propose that we sequence them? Most of these studies have been done after potentially BCMA. But again, I would be interested in everyone's thoughts as far as their optimal. Maybe we can start with Elan, then Natalia, and then go to Noffar and Sabrina.
I don't know if Natalia sorted out her mute option, but I guess not. So I think obviously that's an ongoing area of evaluation and research with these novel agents. We are looking at them in earlier lines of therapy, in clinical trials, CARTITUDE, et cetera. I think that it depends on a couple of factors. How did the patients respond to prior treatments? What prior treatments have they had? High risk, standard risk. I think that the data is pretty encouraging and promising for bispecifics and CAR Ts. So I think that, if they're candidates for that, we should try to push for that. But a lot will be coming, and we'll have a lot more information in the upcoming, months and annual meetings.
Thank you, Elan. And Noffar, Sabrina?
Yeah, so I think at the end of the day, the answer is we don't know. They're all quite effective, and we don't really know which subtypes of patients would do better. But we do have some information that patients who have gain of 1Q have high expressions of the FcRH5. So perhaps, being a little bit more specific in terms of patient selection to some of these, again, more studies really need to be done in subgroup populations. I think it is encouraging that the infection risk is lower with talquetamab as opposed to teclistamab. So for patients where you're more worried about that, maybe in a post-transplant setting where there's other additive infection complications. So I think more to come. We don't know.
I would completely agree. I think there's a question of not only how to sequence our CAR T and bispecifics, but now sequence in terms of targets. So, I agree with Dr. Barr that I think thinking about choosing a CAR T or bispecific, I think depends a little bit on the patient's disease at that time and the time that it may require for them to get the treatment. I think, it's exciting now to have different targets that do have a unique safety profile, and I think a lot of these newer targets are showing response in patients who had prior BCMA cell therapy. So, I think we have the most data, obviously, from our BCMA products, but I think there are going to be patient populations where these new targets, I think, are going to be important and perhaps, our first choice moving forward.
Wonderful. Thank you all. We have another question from the audience. With the results of the IFM 2009 and determination, how do you see MRD driving transplant and sequencing of therapies in general? So I don't know if Natalia or Noffar, you have a response?
Yeah, I can talk about this. I think MRD is going to be driving how we treat patients. I think what we see is in both of those studies, patients who are MRD negative just do better. In the IFM 2009, 30% of patients who had VRD and transplant and only 1 year of maintenance still remain in remission 8 years after. So clearly, we are overtreating some patients, and we need to figure out who those patients are. And I think even with transplant, right? So if we achieve MRD negativity with quadruplets, I think we need to assess, is transplant better? What is the marginal benefit of a transplant in those patients? These studies are underway. We will find out, but it will take many years. Right now, I do discuss costs, risk benefit with patients when I talk about transplant, especially in standard risk MRD negative patients, is patients who I consider not pursuing a transplant and delaying it.
And I'm sorry, I had difficulties with audio earlier, but I do agree with what's been said. MRD does have a value, and its primary significance is in predicting progression-free survival and overall survival. So we do use it in practice as a prognostic tool. And with enough data and with more mature data, we will most likely in the future use the data to discontinue certain patients with low-risk cytogenetics and durable, sustained MRD negative state.
Okay, wonderful. Well, we are after time as it is 1:03. So I will like to thank all of our panelists for their presentations and input today. And thank you all for joining us. Please tune in next Friday for the next in the series. Have a good afternoon, everyone.
Thank you.
Bye, everyone.